trends of tobacco-related cancers in India. He's also looked at the evaluation of compliance with tobacco-related laws in Delhi. We have another officer who's currently looking at the trends of colorectal cancers in India, and another officer who's doing a survey of COPD disease in a community in Haryana. Another officer has done an evaluation of the birth defect surveillance system in Chennai, and because of that experience, WHO invited him to join them in a training to establish birth defect surveillance system in Haryana as well. In terms of environmental health, several of our officers participated in an outbreak investigation of toxin-related neurological illnesses in Bihar. We've established a chronic kidney disease surveillance system in Odisha. We have our colleague in our office who's working on clean cook stoves, which has a lot of implications toward burns and pollution. And we're also in the process of setting up a study regarding health impact of air pollution. And in terms of injuries, we've done a pilot of a burn registry system and surveillance system. We've evaluated the data related to a hospital-based injury surveillance system, and we're in the process of setting up a study to look at road traffic accidents on the Yamuna Expressway. So this is just a sample of, most of this is ongoing work, so I don't even have results to share with you, but just to give you a sense of what we can do with a program like this. And this is the strategy CDC has moving forward. Because the advantage of a program like the EIS program or other similar programs like it, it's not just about the training which creates the workforce to do the work. It's the process of the training. And the process of the training is what's able to allow us to leverage toward getting a lot of this work done in an important area for India. So moving forward, I think we do need to expand our views and work more in all areas of non-communicable diseases. CDC will continue to facilitate subject matter experts providing technical support to India as needed. And we're pushing and promoting for the expansion of NDIS because it's an opportunity to build the public health capacity, not just for communicable diseases, but for non-communicable diseases. And from our point of view, building up the evidence to guide policy is extremely important, and we need more evidence from India itself to help move it forward. Thank you.
For telling us what CDC does in India and your role in capacity building and evidence creation, which is extremely important. I recall just a couple of months ago in this very room, the Minister for Petroleum, Mr. Dharmendra Pradhan, was telling us, as I said in this very room, the money that the government is saving as a result of people giving up their LPG subsidy, that money is being diverted to enable especially women get access to clean fuel to reduce the amount of indoor air pollution, which is causing a lot of health effects, adverse health effects amongst especially women in rural areas. So I think creating that sort of evidence enables government to kind of get traction on this sort of policy that we so desperately need. So thank you, Dr. Sodha, for telling us what CDC does and for the role that it's playing in capacity building and evidence creation. It's now my pleasure to invite Mr. Nitin Goel, who's the Managing Director, South Asia for IMS Health. In his current role, he leads all aspects of IMS Health's business in India, Sri Lanka, and Bangladesh. And so you'll read his wonderful and accomplished CV, but let me just mention that he holds a master's degree in business administration from Kellogg School of Management, Northwestern University, USA, and a Bachelor of Technology from IIT Mumbai. Thank you, Mr. Goel.
Okay. Thank you, Dr. Kathuria, and thank you for all the distinguished guests. I'm happy to have the opportunity here to talk on this session. It seems like preaching the choir here because most of the people here actually are so much involved into the non-communicable diseases. We at IMS Health, of course, we work across a broad spectrum of, we work in the healthcare, but we work as a research organization mostly with the life sciences clients, but also we've been working extensively with other healthcare stakeholders, including the public health organization and the governments. So what I thought I'll do today is, Dr. Bekedam talked about what it takes to kind of drive the NCD programs in the community on a high level or from a top down, as well as some of the examples we have seen. What I thought I'll go more into take a case study. We at IMS Health, we were, for the last 1 year, been supporting the Karnataka government in running a pilot in 2 of its districts, which is built on top of NPC DCS. And what are the learnings from there in terms of actually managing or improving the intervention, the management of the NCDs at the grassroots level? So I thought I'll go through that and share some of the findings we have. Okay, page down. Yes. So I'm not going to go through this slide. I think we have all talked about it. But I think one of the points which I do want to make about in terms of the NCDs, we talk about the health and family and other impact of it, but the economic burden of it is quite significant. I think there's one of the studies that said that NCDs cost $237 billion to India until 2015, but there's another study which came with the Harvard Business School, which says that NCDs is going to cost India around, if you take out the mental health, around $3.5 trillion in the next 15 years. If you take $3.5 trillion in the next 15 years, that's probably somewhere around more than close to $250 billion every year. And if you say in terms of per capita of 110 crore people, that comes around 15,000 rupees per person per year. So that's the cost of, you're talking about cost of NCDs to the economy, around 15,000 rupees per person per year. So if you take that in mind and say, okay, what does it take to invest in it, to try to control it, to better manage it, I think we have to look at that in perspective. So as been mentioned here, that the Indian government does understand the significance or the severity of the NCDs, and we launched the NPC DCS program, National Program for Prevention and Control of Cancer, Diabetes, CVD, and the Stroke in 2010. The main focus was to screen through the camps in the community. It was more of an opportunistic screening. Also providing the screening and the treatment at the CHC level, which was, I think later in 2013 was brought down to the PHC's level. And then community mobilization through the pamphlets. And there was a mention about we should include the secondary and tertiary care hospitals to support the program. And that program, as I understand, has been launched in 100 districts as of 2010, which was later expanded to all the districts in India in 2013. Now, that's a good program that's making quite a bit of headway in terms of the grassroots levels. But what is also happening is, as that's happening, many of the states and many of the NGOs are also building on top of that. So one of the such program, which is launched by the Karnataka Health System Development and Reform Project, is they have built on top of the national program and did a pilot in 2 cities, which was 2 districts, for last 1 year, and has been funded by World Bank. And IMS has been privileged to be able to support or run that program for them. The key approach there was, instead of having the opportunistic screening for these 2 districts, we're going to have that targeted screening of all the individuals which are more than 30 years old. How to do that? The second one was to provide the screening and the NCD facilities not just at the CHC level, but down to the PHC levels. Third was to having more extensive usage of the ASHA and Ammann workers to be actually on the front line to improve the awareness and screening of the population, and also having a very clear referral pattern or mechanism of the tertiary care hospitals, district hospitals, as well as the private hospitals to bring into the overall ecosystem. So what is the program has done by combining that, right from the enumeration of getting people into the system, to the screening, to diagnosis, to treatment and follow-up and referral. In this pilot, the government has invested, or the program has invested a lot more. The ASHA workers are actually going through the household visits to mobilize the people for screening as well as early diagnosis. And more than 200 health facilities in these two districts, and these are rural districts as such, have been set up with the facilities for screening and the diagnosis and treatment, as well as with the trained staff to be able to support them. And then finally, the referral linkages with the medical colleges and the private hospitals has been established. Now, this is not an easy pilot for the government. It has taken quite a bit of time to try to get it off the ground. And it has also cost quite a lot more than a normal NPC DCS program. However, when we look at the results in the last 1 year has been very encouraging when you look at what it's doing for the NCD control management in these 2 districts. So first of all, in terms of look at the screening rate, as we say, we're looking at the screening of all the population which is more than 30 years of age or so. And within 1 year, more than 1/3 of the population, of the target population, has been screened for diabetes and hypertension in these 2 districts, which is way higher than a lot of other similar programs being run. And because of the referral mechanism of the of more than 30 or 40% of the people who've been targeted, 10% of them have been found positive for diabetes and hypertension, which is in line with what you would expect given these geographies. However, I think the more important part is the 90% of those who have been diagnosed positively for diabetes or hypertension, they have been provided appropriate treatment at the PHC level, and this treatment level is much higher than the comparable NPC DCS districts within Karnataka. And one of the reasons for that is because a lot of these treatments were being able to provide it at the PHC level itself. So that has really made a difference. Even the cervical cancer screening mechanism, we have done the work. More than 15,000 women have been screened within 1 year for the cervical cancer in these districts. And that number, when the Karnataka government compares with the other NPC DCS districts within Karnataka, has been around 20 times more in these 2 districts. Now, we are extending this pilot to 1 more year, but the initial results have been very promising. And the lessons that we're getting from these pilots is when you look at the whole continuum of care, from screening to diagnosis to treatment and case management, you have to look at NCD. When you actually go down to the grassroots level, you have to look at the whole continuum, and you have to make sure each of these continuum is managed or is addressed appropriately. And Dr. Bekedam talked about the 4 A's, starting from the efficacy and the accountability. But when you go down to, when we go down to actually on the grassroots, we're talking the 5 A's in terms of ensuring that these programs are actually delivering results. First of all is the accessibility. And we find that the proximity to the facilities, proximity to the healthcare facility is the biggest contributor or the barrier to the accessibility to the healthcare in India. And when the NCD clinics were established at the PHCs level, down to the village level, the access to that treatment and the diagnosis improved significantly. Also, the household visits by the ASHA and ANM workers that improved getting the people to screen for the diseases as well as to actually follow up on the treatment quite a lot. So the accessibility is something that needs to be looked at very, very carefully. Awareness is also the second biggest factor that we find, which is how do you change the behavior change through counseling. And here in these districts, some of the community leaders were involved, and the ASHA members were in the front lines. Availability of the services. We had the PHCs, but having the dedicated and trained staffs and the infrastructure and the drugs and the lab services available at the PHC level was key to be able to make sure there were no broken links in the system. And then the tertiary care services were also provided, but the empaneled private hospitals as well as the public-private partnership for the cath lab services were built into the system to make sure that the whole ecosystem is in there. Affordability of treatment was another one, because a lot of times the patients fall through the systems because, as we say, the catastrophic coverage or catastrophic medical expense or the health expense are one of the largest factor to drive the people to the poverty. But in this case, the government provided the insurance coverage, but in this case, the government sponsored the free drugs and the services at the PHCs for the NCD disease. Now, finding how do you provide these services as well as the drugs as well as the treatments at a free or affordable rates to the patients will be critical to make sure that the patients do actually follow through in the treatments. And finally, the adherence. This is where the role of the ASHA workers was very important, because the ASHA workers each of the patient was tracked, and the ASHA workers did do the follow-ups with the patients at their home, to go to their home to make sure that the patients who were diagnosed positively and were put on the treatment, they follow through with the treatment. So overall, when we look at this particular program, as I said earlier, this is because we're down to the PHC level and we're doing at a very granular level. The cost is higher than what you have in the other programs. But if you look at the overall burden of the cost for NCDs for the nation and what it means in terms of, let's say, the premature deaths as well as the cost of the economy, if you do the trade-off still makes sense. So I think one of the points we'll try to make here, and I think it's for the policymakers as we look forward, is NCDs is a key area for us to focus on. It will require a lot more effort and a lot more commitment, both at the screening level, the treatment level, and going down to the grassroots level and providing the services and the facilities will be the key to actually have an impact on the NCDs going forward. So that's all from us. Thank you very much.
Thank you, Mr. Goel, for telling us about the pilot that you've done in a few districts in Karnataka and the results that you got. You added one more A to what Dr. Bekedam, or at least two, but really one more A to what Dr. Bekedam told us about in a country like India. Affordability is a concern. The last speaker in our panel today, but not the least, is Mr. Ammann Gupta, country representative, India, in the Partnership for Fight for Chronic Diseases, PFCD, and he's been in this space for a while, and he's a communications specialist, apart from being a public health specialist, and he's a graduate from IIT Varanasi and holds an MBA degree from the International Management Institute. It says Indian Management Institute, but I think it's incorrect. And the reason I know that is because he's a former student of mine. And so that is the International Management Institute. And he's also the managing partner at Strategic Partners Group, SPAG Asia. So welcome, Aman, to ICRIER.
Thank you, Professor Kathuria. It's a pleasure to be here, and thanks for pointing that out. I think I've got two mistakes, which I figured out today, one from you and one from Henk. So I know it's always a learning exercise, and especially when we look at NCDs, I think it's such a complex problem, where we have to learn from the past, but we also have to work out a unique and innovative systems and mechanisms to tackle such a complex topics. I don't think there is a solution which anybody can sort of say exists right now, which we can just sort of put up and say, okay, we can tackle this particular problem. Today I'm here wearing my Partnership to Fight Chronic Disease hat, and we have been operational in India for almost 7 years. However, over the last 18 to 20 months is when the speed of the work which we were doing increased manyfold. And the reason pretty simple that while in the first 5 years of our work, NCDs as a subject was not being talked by many. I think we were one of the few organizations which used to try to drum up the support for this particular subject. However, in the last 20 months, many more organizations have started to talk, which I think is a very, very positive step. And if we have to really tackle a problem like this, we need as many organizations who can come out in support of it as it could be. We have heard about the multi-stakeholder approach, and that's, I think, is essential to tackle NCDs because, one, because it is there is a huge burden. The numbers in itself sort of speak about the kind of problem it is, and also because there is no one single player who is required to tackle this particular problem. So we need many more individuals who needs to be sort of working on this thing. So what we have been able to do in the last 20 months is to come out with what we think is possibly a kind of a roadmap, and I'm going to talk about that in detail over the next couple of minutes to just tell you what we have been able to achieve. So just to sort of illustrate who we are a coalition of multiple stakeholders, including patient groups, community, businesses, and the labor groups. What we try to do is we try to do education of the public about chronic diseases and its possible impact and solutions. We try to mobilize the public for change and bringing in a policy perspectives up there, and we challenge policymakers to look at innovative mechanisms to tackle NCDs, because as I said in the beginning of my conversation, there isn't something which already exists, so we need to figure out new and unique ways to tackle this particular problem. What we have done in the last 20 months or so, we have undertaken multiple roundtables, which we had stakeholders which we had from academic side, medical side, insurance side, people who represent patient groups, private sector, as well as the government. We also had a direct engagement with the policymakers, and based over these conversations through direct and through roundtables with more than 150 experts, which represent the things, something which were the insights which we figured out, and I'm just going to talk about some of them and highlight what it really means. One of the key thoughts which we got was that there is a need to now shift the conversation from issue statement to defining and finding what are the possible solutions. Because the first phase of PFCD in the first 5 years which we were talking, the larger conversation was how big the problem is. And I think that particular aspect has been resolved. We know how big the problem is. We realize that what's the kind of an economic impact it can have. What is required now is what needs to be done to tackle it. And as Henk said, the execution of the solution is very, very important part. And the other thing is there is a need for having a more of a patient-centric approach rather than a disease approach. Even if we look at in the current policy framework within the government, and we have been working with the Ministry of Health over the last 2 years, you have multiple programs, and each program looking into one specific disease. So you'll have something for blindness, you may have something for cancer. But as we all know that a person when he comes, he may not have only one particular chronic disease. He will have a comorbidity issues, and therefore when we have to tackle, we have to look at patient at the center and try to see how we can manage and help him tackle such an issue. And therefore there is a need to have an integrated chronic disease care framework. In the beginning, since the beginning of this year, we have been working in multiple states, talking to the policymakers, visiting some of the NCD clinics which already exist, and we do find that there is a gap, that there is no framework which looks into that if a patient sort of comes in and has multiple NCDs, how do you sort of take care of that? The other thing is that in the course of multiple conversations, we do believe that there are workable models which already exist. So the solutions already exist which are being done right now in the pilot format. So whether I will look into the private sector, from pharmaceutical companies to medical devices, to individuals like Dr. V. Mohan in Chennai, or I will find the work which is being done in Ahmedabad. There is a horde of work which is being done in the NCDs, ranging from finding unique healthcare financing models to looking into newer ways of surveillance, epidemiology, to looking into how you can build infrastructure which can take care of the NCDs and the problem. But those are all in a pilot mode. What is required is to see how we can scale some of these up, which are the unique models which really works in the Indian system. And I think the fact that there is a role of both the government and the private sector to come together is cannot be said enough in this particular context. And finally, we need everything. We need infrastructure. We need early diagnosis. We need awareness campaigns. Finally, but somebody has to pay for it, and therefore ensuring that we have a sort of a unique and innovative healthcare financing mechanisms. And I think, as I said, there's not one single person which can take care of it. So there is a need for a sort of a multi-payer system. So we need to see who pays for what, but yes, we need some kind of an innovative and sustainable healthcare financing mechanisms which are there. And that was the, some of the insight which we got based on our, different conversations. And that's what we thought is then required to sort of see, can we develop a kind of a national blueprint which could act as a sort of a guideline or as a reference document for various stakeholders. So that's how we sort of did, and the thought process was to bring in a national advisory group, which was led by our chairman, Dr. Kenneth Thorpe. We also had Dr. Damodar Bachani, Dr. Duraraj, Dr. Ravachandran, Dr. Anand Krishna, who is in middle of us today. He's one of our National Advisory Board member. Under the leadership of the National Advisory, we basically looked into 3 tracks. And each track had a chair who was sort of looking into what kind of possible solutions or what is the recommendation which needs to comes in. And they were divided into 3 groups: surveillance and policy, strengthening of healthcare system, and healthcare financing. So these 3 groups, we had some of the best experts in the brains from across the world. And as you will sort of see, it's a mix of people who represent academic institutions, private sector, government, and I think we got a lot of support from the both the central and the state government, because I think one realization is that there is an urgency which we can see coming from everybody, that we need to do something on an urgent basis on this particular issue. So based on the the recommendations and the whole feedback loop mechanisms, we sort of decided to develop something which we call Sankalp, a commitment to make India healthier and tackle the non-communicable diseases. It's one of its framework with clear focus on multi-sectoral solution-driven approach. It shifts the conversation from issue statement to problem solving and provides key actionable and measurable impact. What we have also done is we've identified some of the best practices that can be scaled up, and currently we are in conversation with the central government to see how we can collaborate along with them to provide a platform, and we are thinking of having an online platform which is accessible for everybody and see how they want to sort of scale it up. And it's finally, we see is it's a tool for stakeholder, including the government, private sector, with a clearly specified role and responsibility on what needs to be done to tackle this problem. Some of the thoughts which are there is strengthening of the NCD department, and what we have seen based on our current conversation, it is happening across states. If you look at UP, where we are a couple of months back, they are looking at ensuring that across all the districts they will have an NCD clinic, and the funding and everything is already in place for it. So, finding that some of the states which you usually does not see as a forward stage when it comes to health are moving very, very actively on this. We also looking at training of the healthcare workers across primary, secondary, and tertiary care, specifically from an NCD perspective, because while they have been working in the other disease condition, NCD requires a very, very a different thought process, and a specific program is being sort of developed for that. And finally, of course, the healthcare financing side of it. I think everybody in this room will echo my sentiment that there is an urgent need for the increasing of the public health spend on the healthcare. However, I think one of the other things which is critical and which we have seen in the past for any large health issue, besides the support from the government, you also need other institutions, whether it's your bilateral organization or multilateral organizations, foundation funds in the private sector, who needs to come in forefront to sort of see what they can do, and that kind of a funding needs to sort of come in. And besides that, I think the role of insurance sector and coming out of the unique systems to support NCDs is very, very important. This Sankalp was released in October. It's a few months since we did it. We have already done our initial conversation with the states. we had a lot of support from multiple organizations. Where we are currently is we are having an engagement with the key decision makers both at the state and the center to effectively push certain policy interventions. Some of them are happening. We were working closely with the Ministry of Health for the draft health policy, and hopefully when it comes, and we do hope that it will come in this particular year, you will find that some of the recommendation which we made on NCDs will be part of that. We have started working with the Indian states. Currently, we are talking to UP, Punjab, Rajasthan and Maharashtra to roll out some of these recommendations, and the first step of that will be happening in next 2 months. As I mentioned, we are looking at these case studies, some of the best practices, and bringing them together. And finally, we do want to focus on healthcare, financing this year, because when we were sort of sitting with in the Ministry of Health, and these were the exact words saying, finally everything else is okay, we need all this thing, but who is going to fund for it? So I think healthcare financing is an issue which even the government realizes has to be tackled, and we need to find unique ways to make that thing happen. And we are hoping that by the end of this year we should have a thought piece, a kind of a roadmap on what needs to be done through this multi-payer system. So from our perspective, as we believe, we are the organization which try to bring all the conversations and various organizations together, because it's not an aspect where only one particular department or an organization or ministry can happen. We need to bring everybody together and ensure that the momentum which is required carries on. So that was about PFCD and the work which we have done. Thank you, everybody.
Thank you, Aman, for sharing with us the work that you do. And also, I'm happy that you went last. In a sense, you echoed a lot of the things that the previous speakers had said and added to them as well, and therefore the importance of surveillance, monitoring, evidence, capacity building, interventions which are based on evidence. And importantly, you also touched on the topic of healthcare financing and scaling up, which I think for a country like India, as Dr. Siyambalagoda had emphasized, you had very large numbers, and numbers sometimes become overwhelming for us in India, and we are indeed a continent, if not, a country of very large proportion. So this has been, I'm afraid there's going to be no time for questions. You'll have to hold your questions until the next session. We do have a technical session, but I think this session has really set the tone for what is going to follow and what are the public policy implications for India. And I just want to emphasize something that Dr. Bekedam has said, and in fact, everybody has said. I think it's especially important for us working in public policy institutions and trying to make change in policy, which is, glacially slow at the best of times, is that, we often present evidence to the converted. We preach to the converted, and we need to go outside and get many more stakeholders involved, and it's all our responsibility, including ours. And I find that not only in what Dr. Bekedam has said in health, but I find that even more in terms of the work that we do on environment, which is linked to health, is that you assemble people in the room who all agree with what you're saying. We also need to reach out to the naysayers and try to kind of present the evidence so that we can make a difference to evidence-based policy interventions. The other thing is that we need to improve in India, I think, is the amount of public spending on health as a percentage of GDP, and that's abysmally low, and we know that, and not only the amount, but also the quality of the spending. We know from history of development, especially of East Asia, that economic growth came about when you had adequate expenditure on health and education. I mean, health and education in India, again, the public expenditure on health and education is low, and that seems to get kind of supplemented by private expenditure, but I think it's important that public expenditure, both on health and education, shows an increase in education at the primary level. And as Dr. Bekedam has also said in his opening remarks, it's important to make the interventions to prevent premature mortality. And therefore, for that, we need prevention and care at the initial stages, and it's important to improve the quality of public spending so that we are able to achieve that. So, with those words and thanking my panelists profusely, Dr. Bekedam, Dr. Siyambalagoda, Dr. Sodha, Mr. Nitin Goel, and of course, finally, Aman. I won't call him Mr. Ammann Gupta, I'll just call him Aman. He's, as I said, been a student. But thank you all very much, and we'll take a short break. But before we break, please join me in giving a healthy round of applause to our panelists. So we'll take a short break. We are over time, but there is a technical session which promises to be very good, and then we'll break for dinner after that. But join us for tea and coffee for the next 5 minutes, please.